Thank you so much, all three of you. Let me just start by sort of plowing some of the same territory as before with you this time. So you've kind of, if I sort of construct in my mind a model, you know, in the earlier two panels, I don't know whether you're here or not, but in the earlier two panels we had one on public health and one on medical care. And we were trying in part to get a sense of how, at the level of a crisis planning, those systems are either engaged or, as we heard, not engaged with thinking about utilizing the mechanisms of response to the crisis to build to an envisioned, idealized future of a healthy community. You're sort of in the middle in some ways. You're like the social services thing is sitting, connecting to the planning, central planning, and you're also connected to the health. So you kind of are in a triangular relationship if I sort of listen to you carefully. So the question, I guess, sort of comes is, first, do you think about health? Not, you've indicated that you think about it in the sense of the sort of immediate psychiatric kinds of psychosocial challenges of the crisis. Do you think about this thing called health in its broader terms in an envisioned healthy state? And then secondly, do you think that the people who are on the ground in real life planning and responding think about health? And what insights you might have on that?
So I will say I think you know, in the Department of Health and Human Services, certainly in the U.S. Public Health Service and the Administration for Children and Families, we think a great deal about the impacts of social and economic well-being on health outcomes. I will say this: the danger in making health the overarching rubric for recovery is that the truth is most health practitioners cannot distinguish treatment of mortality and morbidity, or treatment of morbidity, right? Cannot separate treatment of injury and illness from health. And I think one of the broader questions is, until the public health and medical community can better operationalize how things like social and economic well-being and healthy functioning and community social connectedness and healthy development across the lifespan are part of what they mean when they say health, then there are limits to how effective that language will be in bringing together partners. And I think that that's just an intrinsic challenge, and I do believe that one of the great barriers to interoperability is having a shared language. I've actually done trainings about how to talk to people who do public health and how to talk to people about emergency management. For example, I recently gave a list of 15 words to child care professionals, people who do child care preparedness, not to use around public health people. When they say providers, public health and medical people think they mean doctors, nurse practitioners, and physician's assistants. But they actually mean people who operate child care facilities, because that's what providers means to them. So I just think that, I think there's enormous importance in focusing on health, but we need a broader and more inclusive understanding of health before we can make that the big rubric.
Well, let me, that's it. What a great answer. And again, I signaled earlier that Barry has been patiently in my ear on this very point, and I'm continuing to try to learn. So he's got his tent up, so he'll do his thing. Let me just quickly follow up just one little thing. Just I want to get to it, but for you, Cedar, so you've got rhetorical question. You've got at the federal level control over a funding stream. Could we go to you once we figure out what we want and whatever that is? Can we go to you and say, you know, what you ought to do when you make your funding grants available to the states is to insist on, as one of the criteria, having an inclusiveness to the long-term health issues, so that that as you use the federal dollars, that there's a better ROI on the use of those dollars that goes beyond the initial crisis, but gets to an optimal new normal that can only be achieved if the planning includes a multidisciplinary group of people who are looking to a future state. Could that happen?
I wouldn't say it couldn't happen, but I would say there's a sort of a couple challenges there. The first of all is in reality, the entity that you're talking about that creates the ability to make requirements of states is not executive branch agencies, it's Congress. Okay. And that needs clarification. But another is a number of the kinds of outcomes we're talking about actually are part of the evaluation criteria for existing block grants. I think an important thing to remember is that most of the social services capabilities are not disaster specific or disaster triggered. They're part of the everyday life of how government funds the well-being of people. So they weren't created for the purpose of disaster. Right. But the piece that I think is useful also to remember is this necessarily happens, of course, also in the context of severe gaps for most states in the sufficiency of federal funding to meet their everyday obligations. And I'll give you a real life story. So I won't name the state, but some of us at the federal level were having a dialogue with a state that's done a lot of really innovative practices on child welfare and disaster, a really promising state. And one person from the federal community, not actually from our agency, but from a different one, said, so, is there a way to build this into your requirements? And the state person leaned forward and said, I don't need bad weather for our child welfare system to be in crisis. I'm 40% understaffed to meet my own state's requirements. So when we talk about things like surge staffing, understand that's an everyday reality in a number of these systems. So I think these are some of the real world constraints.
All right, but one I just got to push you one thing though, just because it's going to be key. I just can't. All right, and you're going to give me a hard dose of reality. I appreciate that Congress makes the decisions regarding how these programs work, but do you really mean to say, though, that the regulators, the administrators inside these agencies don't have some discretion around advancing this thematic that we're trying to play with you? Because you can't just say the Congress, unless you go back and get a federal law that says smashing you guys together to do better and to, so on and so on. I mean, come on, there's got to be some discretion inside the agency.
No, absolutely. And I think indeed if you look at a number of the programs we're talking about, great examples would be CAPTA, the Child Abuse Prevention and Treatment Act, Head Start. We can come up with a list of them. There actually are those requirements in place. But I think the real decision-making nexus is not in the priorities made and the decisions made as far as in the level of requirement by human services agencies at the state level. Okay. It's about things like who's in the JFO.
What's that mean?
Who's in the FEMA Joint Field Office? What does human services mean? Have you constructed human services in the emergency response context to refer specifically to the needs of people who are sheltered? Or are we looking at the other 98% of the population who've never come in? So I think there's some real interoperability challenges. Okay. But I also think we do see a lot of progress, but this is a long hill to climb. Yeah.
All right, so Autumn and Lauren, would you just know that since we've got to get to Barry, that we've got to, whatever this thing about who's in the JFO, which I love this language. These kind of things that we're getting from you, this is you're mining gold here, and we just don't have time to. We got to get you to. So don't forget what we're asking you.
No, this stuff we talk about every day at our shop. We'll talk more.
Barry.
Thank you. I just have a really quick point of information, and Commander White in his presentation used the term, and we heard it earlier today, and I just want to point out this distinction for the benefit of the committee, because I think almost everyone else in the room is probably highly aware of this, and that is the emergency phase versus the recovery phase. And so he mentioned, different presenters mentioned ESF 8, and that the first three letters, ESF, are emergency support function. And then a few times there was mention of RSF, which is Recovery Support Function. And in these few minutes, or not few minutes, in this few seconds right now, I'm not going to try to go into that, but it's just very, very important, I think, for the committee's future work, especially because Commander White and others in their presentations referred to the differences between those two phases. But if you don't know that jargon, it may not really make sense when you first hear it. And the importance is that in many of the presentations this morning, those who are involved in hospital acute care are very in tune with the emergency management functions, emergency managers of counties and cities, and police departments and so on, and fire departments. And so they are in tune with each other. When you get to the recovery phase, and Commander White, for one, mentioned or referred to this, then that linkage kind of breaks apart. You don't have the understanding because you're not meeting every week or every month together or dealing on an emergency by emergency basis, not necessarily disasters, with those entities. So the emergency room, the police department, fire department, and the emergency manager know each other really well, or in most cases they do. But when we get to recovery, it gets to be a different thing.
Other committee members, let me just get one last one in, and then we'll go to lunch. So I'm really appreciating your admonitions, and Lisa in particular, about the vulnerable senior and how they're different. Everybody's got their. So the question is sort of, what do you do with that? What does that argue for in terms of a pre-planning system, and what does it argue for in terms of taking advantage of this crisis, being that a crisis is a terrible thing to waste, as it were? I'm thinking about the MRDD population. So the mentally retarded, developmentally disabled, to me, are an interesting group of people, because when you look at the homeless, they aren't the MRDD. They're the mentally ill, but not the developmentally disabled. And the reason I believe, and I'm out of my league here because this is what y'all do for a living, is because there is in place a very rigid, coherent, multidisciplinary, individual-specific plan that is updated every year, and that is and that there are strict rules around how that plan must be implemented. So nobody falls out and drops away. You know exactly where everybody are. You follow them. There's a database that's intense, right? And and it's complete. Whereas the mentally ill don't have it. Is there any lesson to be learned from that model that sort of says, okay, if you can put that together, then you have the chance for resiliency when a crisis hits for these vulnerable populations, because you actually have in place a care management network that meets their needs, whether normally, in normal life, or when a crisis occurs.
Well, I think you've hit on an important point, and that's the idea, is that there is a continuum. So, at one end with MRDD, there's the nursing homes, which are the most regulated and probably the closest to what you just described in terms of having a very clearly articulated state by state what's required in terms of disaster preparedness, as well as the recovery phase, what that looks like. And then you get your people at the other end of the continuum who have maybe aged in place within their original community and now are surrounded by younger neighbors that don't know them as well. They don't have those ongoing interactions. And even though they may be doing well on their own until the electricity goes off and they can't recharge their scooter, or I think they talked earlier about oxygen and special needs shelters, that's when things start to break down during the recovery phase. People think that they can do all right if they're not well integrated into the neighborhood and have a solid system of support. It becomes problematic. I don't think that there's a one-size-fits-all. I do think that where a person resides provides some really important clues in terms of what type of support can be and should be offered.
Well, see, what I'm trying to do is I'm trying to push you to, thank you, by the way, for a responsive answer, but what I'm trying to push you to is not so much those variables, but how do you create systems that can sustain a resilient response, but also that mirror the optimal of what you actually wanted for them in the long term, which is a coordinate. So it isn't haphazard. It isn't, oh, I hope you're lucky that you, no, you have actual systems of care, of comprehensive care engagement with people. Are there examples? Why can't you guys fund that?
I think some people want it and some people don't.
People don't want systems of patient-centered comprehensive care delivery availability? You mean people want to be left dangling participles? Who wants that?
I think that there's some people who really want to be sort of autonomous in their own decision-making about what kind of help they want or don't want.
Then they opt in whatever they want as long as there's the option. Well, I've decided to just be provocative, so thank you very much. I'm not going to bother you anymore. Because these people, see, what happens is the committee will turn on you when they get ravenous.
Well, I'm thinking specifically about special needs shelters. We've tried to start, for example, in Florida, a registry where they've gone door to door to older adults living in the community, like I just described for my last example on that one end of the continuum. And they said, you know, Mr. Smith, Mrs. Smith, would you like to be in the registry? And some people have said, oh yes, sign me up and I'll give you some basic demographic information and health information about who I am, whereas others have said pound sand. So I think that
well, that's not going to be in our recommendation.
yeah, I know. But I think that there's individual variability in terms of, you know, some people, especially older adults, and maybe different groups can talk about other groups, but they don't want to self-identify as needing assistance. They want to be thought of as being vigorous and capable, and that's part of the rub in terms of how do we market this, how do we do outreach to them in a way where it's palatable and it's heard and it's acted on.
Okay. Well, listen. I'm going to go. Look. Don't end it with me saying I'm not. Look. I'm not into this totalitarian horrendousness that you've painted here. I've been miscast. I'm not talking about that. But I am talking about order and structure, and let the individual opt in to whatever level they need in terms of what's appropriate for the needs of the individual. But why can't we just create, said he with his ignorance, create something where you have this system, so it's not just run, scramble, crisis, scramble, run around circles, but that you actually have something that pre-exists with a care appropriate to the individual that then can be built upon. And you can use your emergency response to help continue to stimulate the creation of this model. So that's all. But this is it, and then we're going to go.
You know, I don't think it's going to help you too much, but I can say that on the international side, there's a movement called the Sphere Project. The Sphere Project is something that all international organizations must sign on to. It's kind of an agreed upon system that if you're going to provide health services and public health, that you must agree to do these things. If you're going to do this, common definitions, common language, and so everybody who does as an international organization, you sign on to the Sphere program. So when I came and worked, I did 22 years internationally. I came to the United States and did my first disaster in the United States. And I said, okay, let me have, what is the Sphere standards for the United States? And they all looked at me and they said, there are none. There are no standards. There's no system. There's no structure. Everybody has their own way. And as she said, as Lisa said, many people want to be autonomous. Organizations want to be autonomous. So I would recommend that until we reach that level of developing, whether that starts in the NGO community or with government sectors, you know, until we reach some sort of standards, then, you know, or come to an agreement that those standards are needed, then we can move forward.
Well, there you go. And Cyril will eventually teach us about what he thinks about the Sphere thing, because he's probably got that down. So thank you to the panel. You guys and gals are terrific. And the bottom line on the lunch thing is we were supposed to start again at 1:45, but we'll want to start at 1:50. Uh-oh. Wait a minute.
The cafeteria, the hot food closes at 1:45, so
Rush.
we're a little bit short on time.
So the people that are going to go up to the cafeteria, you have to like,
Down in the basement?
you have to go down, run like crazy. 1:50. 1:50.